The next category of drugs include the kind of the traditional drugs that you would think of in terms of being able to vasodilate. In this category, we're only looking at two. We're looking at isosorbide dinitrate and hydralazine. And so these are, as the text points out, these are great drugs for patients who cannot tolerate either ACE inhibitors or ARBs for a variety of reasons. Okay, so isosorbide dinitrate, sometimes clinically abbreviated ISDN, is essentially a nitrate type molecule, and what it does is it's going to activate guanylyl cyclase, and that's going to produce an increase in cyclic GMP, and this occurs in the vascular smooth muscle. Okay, what does that increase in cyclic GMP mean? Well, it's going to dephosphorylate myosin light chain kinase, and then mechanistically, when myosin light chain kinase is dephosphorylated, okay, vascular smooth muscle relaxation occurs, and so that's going to promote essentially venodilation. We'll see nitrates being employed for obviously patients with heart failure, but also it's kind of the main therapeutic approach to treating angina. Here's what this process looks like. So here's the vascular endothelium, and this is essentially how nitrates promote relaxation, basically through inhibiting the activity of myosin light chain. Okay, so they're rendering myosin light chain inactive. Okay, so the net result here is that when myosin light chain is inactive, you get reduced calcium concentrations in the cytosol, and then that is going to preferentially, at least in the case of ISDN, preferentially dilate veins more so than arterioles. Okay, so what does that mean for the heart patient? Well, if you promote venodilation, you're going to get a reduction in preload. Okay, and that reduction in preload is actually more potent than ACE inhibitors or ARBs can produce. And so that's kind of why when you talk about vasodilators, the nitrate producing compounds are kind of more traditionally thought of as being vasodilators. There is a minor reduction in afterload, and we can show you what this looks like on the next slide. That will produce a reduction in stroke volume. And the intensity or the duration of activity really depends on the formulation of this drug. And so the short-acting isosorbide dinitrate is administered as an inhalant. This is in contrast to the long-acting isosorbide dinitrate, which is administered as a sublingual tablet. And of course, there's a nice accumulation of blood vessels under the tongue. So if you put a quick dissolving tablet underneath the tongue, you can get very quick administration of nitrates to the bloodstream. And so that's the reason they're given sublingually. So you've seen these volume pressure loop diagrams in physiology at some point. So here we're looking at pressure in the left ventricle muscle compared to volume. All right, and so this point here, point B, is really kind of defined as preload, and it's also defined as the end diastolic volume. So nitrates, this is NO is nitric oxide, nitrates push this curve to the left. Okay, they also push this curve, the time in which the blood is ejecting from the left ventricle, right before the aortic valve closes. This is called afterload. They push this down as well. So they reduce both preload and afterload. That's going to reduce stroke volume. Okay, and if you reduce stroke volume, here's the formula for cardiac output. If you reduce stroke volume, you also reduce cardiac output. So this is kind of a nice integration of some of the physiology parameters that you've learned about, and then how the pharmacology changes it. So of course these drugs are not without side effects and toxicities. The most notorious side effect to administration of nitrates, including isosorbide dinitrate, is headache, and that's kind of how we know the drug is working. And so if a patient comes in with angina, or if they have persistent heart failure, once they take isosorbide dinitrate, they will eventually complain of a headache within about 20 to 30 minutes of administration. Okay. Other side effects to worry about include hypotension and orthostatic hypotension, so hypotension upon standing. And that dizziness is basically related to those relatively quick or abrupt changes in blood pressure. And that's really common to all nitrates. When we talk about angina in the next upcoming lecture series, we'll learn a few more of the nitrate-producing molecules, and almost all of them have this common side effect of headache. In the overdose situation, there's a methemoglobinemia that you should be aware of, and many are well aware of the well-known drug interaction that was comedically referenced in the Jack Nicholson, Diane Keaton movie Something's Gotta Give, where the doctors repeatedly asked him if he had taken Viagra in the recent past. And it's well known that you don't want to mix the nitrates, such as isosorbide dinitrate, with the PDE inhibitors such as Viagra. And so that side effect we'll talk about when we go into much more detail of the vasodilators in the angina lecture series. The other drug that you should be aware of is hydralazine. And hydralazine works a little bit differently than isosorbide dinitrate. It still is a vasodilator. Isosorbide dinitrate acts primarily on venous smooth muscle. Hydralazine works on arterial smooth muscle, and the outcome is going to be evidenced by a reduced systemic vascular resistance. Okay, and here we're going to see an increased stroke volume and cardiac output. In terms of pharmacology, this particular drug is kind of a short half-life. So in terms of compliance, patients don't really like taking this because you have to take it 3 to maybe 4 times a day to get a really good therapeutic benefit from this drug. Mechanism of action, we're not quite sure completely. There's 3 kind of proposed mechanisms of action. One has to do with hyperpolarization of the smooth muscle, and that's believed to be operating through a potassium channel. The other is looking at inhibiting IP3, inositol triphosphate's ability to release calcium from the sarcoplasmic reticulum. Remember from anatomy and physiology, the sarcoplasmic reticulum is kind of the storage organelle for calcium. So we're not sure how exactly, but it looks like hydralazine inhibits the ability of calcium to be released from that storage facility. And it also looks like hydralazine is a nitric oxide releaser from the vascular endothelium. Again, not exactly sure, but we do know that when you give a patient hydralazine, its ability to reduce afterload or increase stroke volume is going to be really useful in heart failure. And so that's one of the good attributes about this drug. And so we'll use hydralazine in patients that have heart failure. We'll look at its ability to work in patients of African descent, especially in kind of mid to late stage heart failure, class 2 through class 4 from the New York Health Association criteria. We also use hydralazine in hypertensive emergencies in pregnancy, during post-operative hypertension, and a few other indications as well. So, hydralazine is a great drug. We don't know exactly how it works, but we do know that when patients take it, especially in the context of heart failure, they do quite well. The physiologic outcomes that are involved with hydralazine, again, we said it's more specific for arterial veins, arterial vessels than veins. We're going to see reduced total peripheral resistance, and there's going to be indirect cardiac stimulation. So with hydralazine in particular, you may see rebound tachycardia. That sounds like something we should worry about in a heart failure patient. You'll see why we typically don't, and that really stems from the fact that the heart failure patient is on several other drugs. Okay, the side effects are listed here. Headaches, again, flushing, tachycardia, lupus-like syndrome, and so forth. These are all associated with hydralazine. Understand, too, that hydralazine is often combined with isosorbide dinitrate, and we like to combine them because we've got 2 different mechanisms producing venous and arterial vasodilation. And we've also found that this combination works well in African patients and can be combined with other therapies.